Yeah, thank you very much. So this is Dr. Rajneesh Kapoor from Medanta. Yeah, great. So I hope you guys are having the best of the times at WOPI. And some time back there is a live presentation which has already happened from Medanta. It's second in a row. So there was some change in plan. You know, initially we planned a case which was a chronic total occlusion. We started that case almost 1 hour back. So can I just show you that case and then, so there is some change in plan now, which the case which we are dealing is different, but just 2-3 minutes I'll take upon the case which we started. We are not carrying forward because of certain reasons. So I think, can somebody show that angiogram?
Okay, we can see the angio.
No, this is, sorry. So I'll just take 2 minutes before coming to this case. Okay, so this is the angiogram you can see.
Yes, we can see that.
So this case was initially planned to be done here. So as you can see, the left system is normal, and there is a big septal branch of LED which is giving good collaterals to right coronary artery. And I'll show you the right coronary artery also. So this is the right coronary artery which is totally occluded in the mid zone. And in fact, this patient has been quite symptomatic, and stress thallium was ischemic to the tune of around 20%. And there was a failed attempt outside, somewhere outside, where they tried to open up this CTO but couldn't. So initially we thought that, you know, dealing with coronaries, putting stents in simple lesions is pretty common. So let's try this out to be shown in this meeting. So obviously once it has been failed outside, so we planned a retrograde. So this is, we took the corsair into the septal artery and giving us selective injections. So there was some collateral, but we were unable to find a concrete track. So there were very flimsy small channels which is through which the RC was filling. And then we tried various channels to enter into the RCA, but then not finding absolute concrete track, as you can see. We tried various channels. So this, again, it's not filling up the RCA here in this septal branch, but this is the collateral which is filling the RCA. So we tried this channel also next. Okay, next. Anyway, so crux of the matter is we were trying this case for 1 hour and thought that it will be really thought-provoking if we can go to a retrograde route and cannulate the RCA from the retrograde route and discuss all the points of CTO opening through a retrograde route. But somehow we were not able to do so because there was no concrete channel we could find through which we can enter the right coronary artery from a retrograde route. And then we tried the antegrade route also, but then if you decipher on angiogram, there is a branch and it's a blunt occlusion. So we just changed our plan and have another case now, but I just wanted to tell you that this was our initial plan to discuss all the retrograde CTO. Anyway, so if there is any discussion on this, we can do that and come to a present case.
Okay, thank you very much. I think it was a great and honest presentation of the previous one. And we are ready for the next patient.
Yeah. Okay, so this is the patient presently on the cath table is 47-year-old guy who had, not this case summary, this, okay. So 47-year-old male patient who's diabetic, hypertensive, had chest pain on 14th of April, few days back, and it was diagnosed as anterior wall myocardial infarction. On echocardiogram, the LED territory is hypokinetic with an ejection fraction of 40 to 45%, and patient has been still symptomatic, complaining of post-infarct angina. So this is the case summary, and now we'll run you through the angiography views. So this is the left-sided angiogram. You can see there is some plaque in the mid left main. AP cranial, next. So this is AP cranial, LED is very tight in the mid zone, extremely tight, very critical blockage, quite a lengthy blockage, and then towards the distal part also there is a small discrete focal lesion. So this is the angiogram of the present case. Next. And if you see the left main in iliacaudal view, next. So this is, so it looks like a 30% stenosis in left main. So our plan is that we'll investigate, we'll have the analysis of this left main stenosis by OCT, and then stent the LED with two stents, the long stent in the mid LED and a small stent in the distal LED.
There's a huge intermediate branch. Isn't it a lesion at the bifurcation, or it's not significant? I cannot clearly see it on the screen.
That seems to be a borderline lesion around 70% in the intermediate branch. Yes, at the bifurcation.
Okay.
Can we have the OCT pre-run? Okay, give me OCT. So we are going for a OCT run.
So are you going to do the OCT for the LED lesions and the left main in the same setting?
Yes, yeah.
And you will decide the strategy after, based on the result of the OCT, right?
Yeah, practically we're looking at the left main lesion, how significant that is. Visually it looks around 30%, but let's see the OCT analysis. And also the length of LED lesion, it seems to be quite a long lesion, maybe more than 50 millimeters.
So for the LED, the plan is to cover the whole disease segment with one long stent or with two focal stent implantations?
I think with two stents perhaps, because one long stent may not cover the two lesions. One is a long lesion in mid LED and another one is a shorter one. So let's see if the length comes out to be 50. We have a maximum length stent which is 50 millimeters. Otherwise, we may have to use the overlapping two stents. Ready?
Yes, sir. Already ready.
No.
20 ml syringe. 20 ml syringe का है?
Right.
22 से भरनी पड़ेगी. ये लो. ये और आई है.
Sister, listen to the patient.
डाई देना और डाई.
Okay. Tell me once you're ready. We may have to take two shots. It's not covering the left main. हाँ कर रहा हूँ. Okay. Ready? आया नरेंद्र को और करता हूँ. Is it a good run?
नहीं डाई सारा अंदर बसा हुआ है. नहीं है. ब्लड है. ये लो इस पे ब्लॉक करो.
Okay. Have a run again forcefully. Ready? एक मिनट enable होगा पहले. Are you ready?
बताना इनेबल
Okay.
गाइड
Sure.
सारा बाहर था गाइड सारा बाहर
Huh?
गाइड अंदर करो ना
Okay, you have a mic, Dhiren? Yeah. So can you have a look at the OCT? Is it visible in front of you?
Yeah, we can clearly see it. Yep.
Yeah, there is some mixture of blood there. It's not very clean, but yes, it tells us that it's a very tight lesion. Can we have the length of the lesion, Dhiren? And this does not contain the left main, for which we will have another run. Give me the length of the lesion. It's a very long lesion. Check. Are we inside the left main? देख के ear का क्या हुआ?
डियर करता हूँ टेंशन मत लो
Are you measuring now the length of the total LED disease segment?
Yeah. Yes. 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 How much? It may be more, it seems, you know. Huh? So the length of the mid LED lesion is around 40, and what's the vessel size? Left main के लिए तैयार हो, एक और भरना.
मैं ले सब रेडी है
So how long was it altogether?
So the length of LED lesion is around 50 millimeters, and I'm taking back the OCT catheter to show you the left main lesion. Check. Okay. Okay. We're going for another run for left
नहीं
main.
रेडी बोलना है
Enable करो. अच्छा देना पड़ेगा.
अंदर होगा तो ले लूँगा
पर्च कर दो थोड़ा.
रेडी
Yeah, go. Yeah, okay. Now show us the left main lesion. I think that's the major question. It was LED lesion, we know we have to stent it, so the additional information which OCT gives us, the size of the vessel and the length, but the key question is, so how does the left main lesion looks like on OCT? So we're coming back, and it's a good run. This is circumflex. So this is left main. Is it visible on your screen?
Yes, we can see it. Yep.
Show us. So this is the one.
ये मिनिमम पॉइंट होगा
Yeah, just measure the area here, maybe, yeah. So this is that part of the left main lesion on OCT. So we are going to measure the area, and we know, there is a cutoff limit. So it looks like a spacious vessel here. So I don't think it's a significant lesion as it looks on ACT, but we'll give you the figures. You measure the area here.
Is it the LED segment just before the bifurcation?
Pardon?
Which segment of the LED is that? Is before the bifurcation or?
No, this is left main. This is the left main segment.
Yeah.
The left main where the lesion is, this is that segment.
Okay. So 4.9.
Yeah, so 4.9 is looks significant.
Maybe should change the strategy. 4.9 is almost stenotic,
Yeah,
below 6.
yes.
So you have a LED and the left main.
Yeah, so then if it is 4.9, we may have to think of the left main also. But do you think we should further corroborate it by FFR once we are done with the
Absolutely.
LED lesion?
Absolutely.
So what is the
FFR.
view of the panel on this?
Our opinion in the
Yeah,
panel is
so I think let's first,
yes, in the panel
Yeah,
we
please.
think that we would suggest you to go for the FFR.
I also
right.
think
So
that you
after
should
we
do
have
a
stented
F-
the LED,
After stanting the LED, it's logical.
Yeah.
yeah, yes. So we plan to do a FFR and further have this evidence whether this is really ischemic or not. Okay, so let's first have the small stent distal.
I think small sand distal.
Keep the FFR ready, we'll do the FFR after stenting to LED.
I personally think that if you have IFR, you can measure IFR with the wire, you can understand exactly either your LED stenosis, either the left main with the difference in the values. And for me, it's a quite good method to evaluate the length also of the stent in the LED. Otherwise, if you do adenosine,
Yeah,
it's better
I know,
to stent the LED and after that to perform left main.
2.5, 12.
2.5,
12.
12.
So we are going for the distal LED lesion first with a 12 millimeter of
Daivara.
stent there, 2.5 millimeter diameter. Can we have the lineage? So we have these stents, lineage stents by Merrill. So this looks to be a very good stent in terms of that strut thickness is only 65 microns. And it's a cobalt chromium based with a biodegradable polymer, sirolimus eluting stent. The deliverability, they have changed the deliverability catheter, and the best point is the strut thickness. So of late we have gone down on strut thickness with 60 to 65 microns stents available, and we know that getting down and maintaining the radial strength with these kind of stents is going to be very good.
FFR ready करना है दुबे जी FFR
Come cranial. Slightly more RAO. Okay. Sure.
The plan is to put this relatively short stent distally and put a longer stent.
Yeah, short stent distally and a long stent. Yeah,
With some overlap.
that's the plan.
Okay.
Oh, okay. Go up. 6, 8. 6, 8. 10. 12. Down. So we deployed the 2.5, 12 at 12 atmospheres. Okay. Take a shot. Now tell me, 50? Should we take 50?
50.
Yeah, as per OCT it was 50. So do we have 2.75 50 lineage? Five zero.
Is it the longest version of this stand?
48 law
Fourth date of 50?
Yeah, so maximum length we have available is 48 millimeter. So we're going with that. 2.75 48 millimeter lineage stent from Merrill.
From technical point of view, do you feel any difference in deliverability compared to the Biomime previous generation?
Yes. So they have done modification in this delivery catheter, the shaft of the stent. It's actually, there is at the junction point of balloon to the shaft. So there is no, I would say no transformation. It's a single piece thing. So the deliverability is much better with this.
Okay.
So actually on the OCT it was clear that this LED is quite a fibrotic lesion. So I can actually face a resistance while advancing this stent. Check.
ओवरलैप हो जाएगा, ओवरलैप.
Let's see. Check. हो जाएगा.
हाँ, जस्ट टच है, आगे आना पड़ेगा इससे.
Can we come back?
I think you should reply here. आगे बात लग रहा है.
And come back a little bit. Check. Yeah.
डिस्टल ठीक है.
So this is the best position we can achieve.
बस आगे जाओगे हल्का सा.
आगे नहीं जा सकते.
बस फिर ठीक है, करना पड़ेगा.
Check. Okay. Go up. 6, 8, 10. Down.
It seems that the proximal part didn't open up completely. Do we agree?
No, it did open up. There is a fibrotic lesion, which the tightest most lesion in the LED is quite fibrotic. So we definitely need to do a lot of work there with post-dilatations.
2.75? 2.5.
Check. So this is how it looks after stenting, but still, as I mentioned, a lot of work to be done with post-dilatations. So let's have a 3 millimeter.
3 millimeter, 3.8.
3.0 into 8 millimeter non-compliant balloon. And then keep the FFR ready. While we've done this, we'll do the FFR.
What was the inflation
So
pressure?
any discussion point? Yeah. Pardon?
What was the inflation pressure of the long balloon?
So 12 atmospheres. 2.75 into 12. At 12 atmospheres we deployed this, and we're going to post-dilate with 3.0 balloon, 3.0 into 8.
डालो बस.
Okay, go up. 6, 8, 10 down. 6, 8, 10 down. Check.
Is there a small gap in between the two stands? Or are they overlapping?
There is small gap, so no, they are not exactly overlapping. There is a small gap, so stent was falling short, but then, we were not getting a good overlapping zone. Go up. 6, 8, 10.
Yeah, but luckily that segment which is not covered
12.
in between the two stands
13 down.
was not diseased in the beginning.
No, it's a good normal segment, so I don't think there is an issue in leaving small segment also. Go up. 10, 12, 14, 15 down.
FFR.
Yeah, 10, 14, 15, 16 down. 15, 16. So this is a fibrotic part down. Cranial थोड़ा कम करो.
Edge.
Okay, go up. 15, 16, 17, 18, 19 down. Check. Come cranial. Cranial जाओ. और
थोड़ा सा प्रॉक्सिमल पे, थोड़ा सा आगे लेके 1 मिलीमीटर
जाओ. 18, 20, 21 down.
540 का रेसिडुअल है हल्का सा, ठीक है, हल्का सा आगे
जाओ. 20 down.
जंप किया, 20 पे 18 पे जंप किया,
जाओ. 18, 20 down. 22, 3 कर लो. Go. 20, 23 down. Check. Yes. So we are aggressively dilating this. Go up. 20, 23 down. So 3O balloon at 23 atmospheres. Cranial.
What is the name of this non-compliant balloon?
Mosaic.
मोज़ेक.
So this is a mosaic balloon, which is a non-compliant balloon, and let's see what size it achieves at 23, 3O balloon. Okay, can we have the FFR, or we can have OCT run prior than the FFR? Okay.
By NGO, the LED looks very good.
Yeah, so we give you a OCT run first and then the FFR. Flush कर. लेफ्ट मैन के साथ ही रखते हैं ना, मिडवे नहीं, उससे 20 सीसी 20 सीसी.
कहाँ है सिरिंज, कहाँ है?
ये
अच्छा, ये तो आगे पोजीशन दिखा देते हैं.
चेक. Check. Is covering this. So we're going for a repeat OCT run. So as the size allows, it will only cover some part of the stent, and we want to come back to the left main again. So we wish to have the area analysis again on OCT, and then give you the figures and then do the FFR. Ready?
कैसे कर दिया?
Ready? Huh? Okay. Go.
बोलना.
हाँ चलो ना.
बोलो.
Okay. नहीं, it's from the mid we started. It's fine. Or keep coming back, yes. So stent looks well opposed. Can we run the OCT as a this thing? Run अच्छा नहीं है.
गाइड अंदर करो. गाइड अंदर करो.
So should we have another run? Check.
गाइड अंदर करो ऐसे.
Okay, ready?
रेडी बोला है अब.
Tell us.
शूट. अब देखो, बहुत जबरदस्त.
This is good. So sorry about that, the first run was not really appropriate, so we got another run, and this looks pretty good. So move slow. So we are coming from mid part of the LED stent backwards, and you can see the stent struts are well opposed. So it looks good here. We're coming back. Yeah.
Yeah, the stent opposition is very uniform. It looks very nice.
Pretty good, yes.
तो बहुत अच्छा है
This is diagonal, no?
वो
This is diagonal.
mouth और diagonal
It's fine. Come back, come back, come back. Don't stop. We want to see the left main now. So this is the proximal LED area, and now we are now entering the left main. Okay, come slow here. Yeah, more, more, more. Can we have the area here once again? So this is that part of left main which we have been discussing, and let's have the analysis again and then keep the FFR ready. So it's a stable plaque otherwise, but let's see the area. FFR. So it's quite reproducible, almost the same, 4.82, and previous analysis was 4.9. So from this aspect it looks significant. Let's see the FFR measurement. FFR.
From the audience, how many of you are thinking that the FFR will be positive? How many of you?
I think
One,
that's a very
two,
good question. So let's have voting.
Only two.
करूँ on
And how many think that it's going to be negative?
on
Almost 10, 11.
Okay, so the majority thinks it's going to be negative, or at least non-significant by FFR.
Yeah, so I don't know. This discrepancy is commonly seen. What's your experience about it? Normally 6 millimeter square area lesser than this, obviously, there was some correlation between abnormal FFR and in left main especially, but there are situations like this which are pretty unique. Visually it looks like 30-40%, not more. Area comes out to be 4.9. So let's see the FFR. Even I think that it should be negative.
ये देख सारा पानी आ रहा है यहाँ से
In this case, personally, I would rely on the FFR measurement.
Yeah. Okay. So we're right there with the wire. Yes. Okay. Caudal, RA caudal.
और अंदर करना पड़ेगा अभी नहीं
Okay, equalize here. Okay. Yeah. Okay, epicranial.
बोला सी देंगे हम कहाँ है एडिनोसिन वही तरीका है इन्फ्यूजन नहीं है एंटीजी देना है पहले एंटीजी एंटीजी का एंटीजी इफ यू वांट एंटीजी इफ यू वांट टू गिव बिफोर
Adenosine though, no? Adenosine.
एडिनोसिन तो ये रहा
Okay. So what is the baseline value? So I think it's visible on your screens. It's 0.94 is the baseline. I'm ready to give the adenosine bolus. Okay, let's see. So as you can see, not much moved. This is post-adenosine bolus. The minimum value up till now we're getting is 0.90 or 0.89. So as expected. And I think most of the panel and the audience is right.
Yes, we are not surprised.
Yeah. So do you wish me to have a second bolus or we stop here? Because what in our experience, the FFR values are highly reproducible.
Yeah.
Usually they stick to the same thing.
If it were 0.82, I would suggest to go back with a bigger bolus, but at 0.90, I think.
Yeah, I agree with that.
I can
In
accept
case,
it.
yeah. So in case it's borderline, we can still think of adenosine infusion or something, but so this is the second bolus, so value is absolutely the same, 0.88, 0.89.
What was the amount you gave?
So I think, pardon?
What was the amount of adenosine you gave?
Adenosine we have given almost…
180 microgram.
Huh?
180 microgram.
No, how much total?
बोलस में 180 होता है माइक्रोग्राम टोटल
180 micrograms, yeah.
Well, it must be
So I'm
enough.
taking out the FFR wire and
तो discrepancy between OCT
this is the one, no?
and
Give me the torquer. I just wish to advance this wire. So any discussion points up till this? So I think the decision is made that we don't want an intervention on the left main. After getting the LED fully patent, the FFR to left main is negative.
Yeah, and the sensor on the FFR wire was pretty much distal. So probably the FFR
It
of the
was
left main
distal
itself.
to the…
Yeah.
Yeah. Come areocranial. Okay, show us a shot now. So this is how it looks post-stenting. We have used a long stent in LED and a small focal in the distal LED, and it looks pretty good to me, and we've checked it with the OCT, well-opposed stents, and there is some lesion in left main, but it's not functionally significant, proven by FFR, and that's what I think we are done up till this point. So any of the discussion points, any of the things which you want to give inputs up till this point?
Okay, thank you very much, Rajesh. It was an extremely good case. Congratulations to that. And special thanks for showing us the CTO case as well.
So that was the initial plan, Dr. Fontos. So we are a bit sorry that we couldn't do that. We wanted a huge discussion on the retrograde CTO, but somehow we couldn't find a concrete channel to enter. And thanks, and Dr. Himanshu, Dr. Dhirendra is here with us. So full team was geared up, and there was then sudden switch that we had to take this patient, because then once we were not entering into a retrograde channel, there was no point, because there were no discussion points.
Okay, I agree completely with you. And thank you again for the beautiful case, and congratulations to the whole team. Hope to see you soon.
Thank you, and have a wonderful day ahead.
Thank you.
Thank you. Thank you. Yeah.